Welcome back, ladies and gentlemen. I hope everybody had a lovely tea and coffee. I'm sorry it could not be at our expense. And now we'd be moving on to the much anticipated debate, and I hope everybody enjoys it as much as it is expected and anticipated to be. The first is I'd like to welcome our moderators, Dr. Vikram Huded and Dr. Raj Srinivas Parthasarthi. Dr. Vikram Huded is a senior consultant interventional neurologist and the head of neurology at the Narayana Health Institute of Neurosciences at Bangalore. And his areas of interest are neurointervention and stroke. And Dr. Raj Srinivas Parthasarthi is the head stroke unit and senior consultant of neurointervention at the Artemis Hospital in Gurgaon. I hand over the mic to Dr. Raj Srinivas and Dr. Vikram. Over to you, sir.
Yeah, at the outset, I want to thank Padma Madam and Rohit sir for giving me this opportunity. I think this is an interesting debate. And I think even RCTs are not there and RCTs are on the way to do whether mechanical thrombectomy in low NIHSS with MO occlusion, whether we should do it or not. So for the debate, I call Dr. Suhas Murali.
We have this case scenario. I'll begin the debate with this case scenario where we have a 65-year-old gentleman who presented within the window period within 3 hours. Within 3 hours of stroke onset. At admission, his NIHSS was 2. He had an aspect score of 9, and on CT angio, he had a M1 distal occlusion. Now, what do we go ahead? How do we go ahead? Whether we take him up for EVT or not? That is the point of the debate. This is the first debate, and I am speaking for the role of EVT. Yes, and most definitely yes, that we need to do it. I thank the moderators, Dr. Vikram Huded sir, Dr. Anand Alurkar sir, and Dr. Raj Srinivas for chairing the session. There is every debate in stroke begins with this the old adage: time is brain. This slide has been repeated in a number of stroke conferences the world over. In any case of a supratentorial large vessel occlusion, we begin to lose millions of neurons per second. For example, per second, we lose around 32,000 neurons, wherein we age by around close to 8.7 hours per second. We are losing close to 9 hours per second. But here, among this thing mentioned, we have the neurons lost. But nowhere in this debate, nowhere in this table have we mentioned where the neurons are lost. If the neurons are lost in a particular point, they have a specific function that they perform. It causes a significant loss of function, and thereby the quality of life is impaired. If each second, I'm going to delve on this for one slide. If, for example, the locus coeruleus is a structure which has around 36,000 neurons only. If we are losing, for each second, if we are losing close to 32,000 neurons, the locus coeruleus should get destroyed in 1.1 second. This is the importance of this slide. Remember, the time window is no longer crucial right now. We have something called as the tissue window, which is far more important, because where the tissue is lost means that we have loss of function. And how do we assess function? It is by the NIHSS. Now we have three actors in this debate. The first actor that we have in this debate is the low NIHSS. The second is a large vessel occlusion. Now, what best fits this pie? Whether it is the conservative medical therapy or is it a EVT? First, we need to see how common are these minor strokes. What do we mean by a minor stroke? What do we mean by a low NIHSS? By the traditional definitions, we have understood that low NIHSS means as a score of less than 5. If we see in this stroke Cincinnati registry, we found that close to 50 to 60%, more than 60% of patients were actually presenting with a score of less than 5. Most of the strokes are minor strokes. They don't cause much disability. Remember this slide. I am going to come back to the other importance of this. Most of the trials that we are dealing with are based on the NIHSS beyond the NIHSS of 5. but yet the majority chunk that we actually deal with are the minor ones. Now coming to the second actor in the debate, we have the middle cerebral artery. If there is a occlusion in the proximal segment, the proximal segment is around 3 millimeter in diameter. What happens when there is a occlusion in the proximal M1? As we age, our appearances change, but the goal of life is to keep smiling throughout, but our appearances do change. So does the appearance of an infarct. As the infarct begins to age, its appearances also change. But the goal of treatment, all our stroke care treatment, the increased awareness to catch the patient within the window period is to catch the stroke in the early part. Now we have caught the stroke at the early part, thanks to the awareness. Now how we should know, how does this stroke look like? What are going to be the clinical features when we actually encounter a patient who presents early? Will he be in the window period? Definitely yes. Will he have a higher aspects? Definitely yes. As a result, more number of neurons are still salvageable. They are still functioning. Hence, the patient is still functionally capable. That means his NIHSS score will be very low. Now, let it proceed in its normal way. As the infarct ages, there is more and more number of neurons begin to succumb to the infarct. As a result, the NIHSS also begins to worsen. This point is very critical. Now, does all NIHSS mean poor out, or does all NIHSS being low NIHSS mean that the outcome is automatically good? Definitely not. This is because in this cohort, in this study which was done by Smith et al., which was published in Stroke in 2011, they found that surprisingly, the so-called minor strokes who have an NIHSS of less than 5, among them, close to 40% were not discharged to home, and close to 38% at the end of 3 months were not ambulating independently. That means there is some amount of progression that is happening even though the patient has a low NIHSS admission score. It is important to note that the NIHSS has an inherent fallacy in predicting the outcome of a stroke at the end of 5 years. Basically, remember this, low NIHSS score does not mean that the patient will have a good outcome. Now, does low NIHSS score mean that the patient has a no occlusion or a small occlusion? Definitely not. Now, as I had shown this slide before, most of the chunk of the strokes that we have are minor strokes. But it is interesting to note that when we categorize the NIHSS below 5 and look at them separately, the percentage of those patients who present with a low NIHSS still have some significant percent of occlusions in them too. The catch is to treat these patients so that they do not progress further. Low NIHSS does not mean that there is no occlusion. So what happens if we leave a patient with a low NIHSS who has a large vessel occlusion? If we leave them, what happens? Most commonly, they progress. In close to 8.7% of patients, they progress. And they progress very fast. They progress within the first 3 days. Now, some patients might progress very quickly, who are called as fast progressors, and some patients may progress much more slowly. They are called as the slow progressors. This particular factor depends on the collateral supply, the status of the collaterals. But because there is a significant volume of brain tissue that we are going to lose among the fast progressors, this is the cohort that we are mainly interested in to intervene. The whole crux of the debate will be on this slide. Whenever there is a large vessel occlusion, say for example, in the MCA, there is a clot lodging in the proximal segment. A large area of the brain tissue is going to go into oligemia. As soon as this brain area is hypoperfused, immediately it begins to draw more blood through the collaterals, and the collaterals should normally open up to help the penumbra to survive. But If the collaterals fail, then we are in a big trouble. The major point of any acute stroke care thus relies on the 3 C's: core, clot, collaterals. Now, a patient has a low NIHSS, he has a large vessel occlusion, but the disability is still worsening. What could be the possibility? As I've discussed this already previously, the most common is if there are no collaterals or the ones which are there begin to fail. Secondly, there could be distal occlusions causing disabling symptoms, or the third could be a recurrent stroke. What are the temporal evolution of a patient who have large vessel occlusions? This is significantly important because if the patient has an LVO as compared to a patient who doesn't, most of them, close to 38%, are bound to have early neurological deterioration. And most of them are at the end of 3 months, close to half of the patients with an LVO will have a very poor or a disabling stroke. LVOs cause early deterioration and LVOs cause significant disability. Hence, we have to intervene. So let us settle the first half of the debate. Does low NIHSS mean with a large vessel occlusion, does it mean a good outcome? Definitely not, because if we have a patient who has a low NIHSS in the region of 5 or less, among them in this study done by Rajaji et al. In Florida, it was found that close to 30% of LVOs are still missed. Remember, it is most important thus to protect the proximal vessels. Hence, the crux of the first half of the debate is, if a patient comes with a low NIHSS and has a large vessel occlusion, open the vessel. We are dealing with a twin or a masked person here. M1 occlusion is an evil person who has come with a mask of a low NIHSS. We are here to unmask it. Now, how do we go ahead with management? Do we go ahead with the medical management using the thrombolytic agents, or we go ahead with medical therapy, or do we go ahead with thrombectomy? First, to understand this, where are the vessels most commonly occluded when the patient has a low NIHSS? In this study, which was called the INTERSECT study, it was found that although the most common site of a LVO in low NIHSS was found to be M2 with close to half of the strokes, the proximal M1 is not lagging behind. It's close to 29%, which is almost 1/3 of all these patients. So we have a large chunk of patients who can present with an M1 occlusion, but yet have a low NIHSS. So how do these people progress? If they have a large NIHSS, how do these people progress on treatment? Say, for example, for such patients, we give a thrombolytic agent. The rates of recanalization in the proximal vessels in M1 with IVTPA is around 30, this is 1/3, close to 33%. Whereas with endovascular treatment, the same cohort will have close to 43% vessels do open up. The same thing with the proximal ICA, the ICA terminus too. Now, we need more evidence. Come on. So we'll go ahead with this thing. In this trial called from the stop stroke or the Gestor cohorts, it was found that the cohort who underwent the endovascular treatment did have a very good outcome with an MRS score of less than 2 in close to 90% of the population. Whereas those who underwent medical therapy had close to 70% at the end of 3 months. More data is piling up. In one more study in China, it was found that those who underwent thrombectomy at the end of 3 months had close to 55 to 60% of patients who had a good functional outcome compared to the conservative therapy. What are the outcomes? What are the outcome rates if the patient between the comparison groups in another study? How low can we go? How low can we go for thrombolysis? In another study, it was found that those who underwent EVT for M1 occlusions, close to 53% had a good outcome compared to 24%. Evidence is piling up, so it is inevitable that over a period of time it does get accepted. More evidence. MRS at the end, in another study done in Netherlands, it was found the same thing. Those who underwent endovascular thrombectomy who had a low NIHSS.
Suhas, your time is up. Can you conclude?
I'll finish, sir. So more data will have more confidence, and this is what is important. The rates of thrombectomy are increasing in large vessel in more NIHSS, but the chunk with low NIHSS also is increasing. Today is the 7th of August 2021. On 47 years earlier, this person called Philippe Petit, who was from France, did the unthinkable, walking on a tightrope between the two twin towers in the US. Today, I am doing the tightrope walk between low NIHSS and LVO, but the data is limited. Then with 2015 came the large trials, which obviously had selected NIHSS more than 5. But one good thing that they did was they gave a lot of confidence by reducing the number needed to treat. Thus, then came the Hermes, who's the messenger of gods, who also gave us one critical message. The data for patients with NIHSS less than 5, we need more data, but EVT is the way forward. So now we have more and more data that is piling up. There are randomized control trials that are on the way in the pipeline, and hopefully before the next debate, this will help me cross between the two towers much more easily. The cake is complete. I would like to keep EVT as the third part of the cake. Thank you.
So it was a very excellent presentation. Now I call Dr. Harikrishna for the no debate.
Good morning to all. Today the debate is on endovascular thrombectomy in a low NIHSS and MCA-M1 occlusion. No, we are actually making it worse. We know the case. This is a 65-year-old gentleman with a right MCA minor stroke with right distal M1 occlusion. With a favorable CT aspects of 9, his stroke score is 2 and angio showing a distal M1 occlusion. So how do we proceed in this case? What does the current AHA guidelines provide? What evidence do the current AHA guidelines provide? In a patient coming in the window period for thrombectomy, that is in the 6-hour window period, there is a class 1 recommendation with the level A evidence for a patient with a stroke score more than 6. Whereas in a patient with a stroke score of less than 6, as in our patient, the benefits are uncertain for mechanical thrombectomy, and it may be reasonable only with a class 2B recommendation and a level B evidence with some randomized data showing evidence. Before proceeding to the individual studies, I would just like to briefly tell about the natural history of minor stroke with large vessel occlusion. So this specific subcategory, as my friend has already pointed out, this is a specific subgroup of patients, and 20% of the patients with acute ischemic stroke have a stroke score less than 5. And among them, 1/4 have got a large vessel occlusion. 30 to 35% of these patients are still functionally dependent at the discharge also. We know that all the 5 pivotal EVT trials proposed that endovascular therapy has got a very good outcome in M1 occlusion or a large vessel occlusion. But in the Hermes meta-analysis, only 14 out of the 1,740 patients were represented for the analysis with a stroke score less than 5. Another caveat in this subset of patients is the utility of NIHSS score for assessing the disability. We know that a patient with NIHSS 2 may have a disabling or a non-disabling stroke depending on the functionality or whatever deficit is present. Patient with hemianopia still has a score of 2, is functionally deficient. So that exposes the problem of NIHSS in assessing a disabling stroke. So overall, there is a clinical equipoise in this subset of strokes, whether to proceed with an endovascular thrombectomy or an IV thrombolysis. The evidence currently is uncertain. There are no randomized control trials available. Only observational studies are available, both prospective and retrospective data. In any case of large vessel occlusion, the most important predictor of a good outcome is recanalization. And acute neurological deterioration in patients with the large vessel occlusion and minor stroke was studied to look for any predictors of early neurological deterioration in the study. This was published in Stroke in 2020, And they found there are no clinico-radiological predictors which can identify early neurological deterioration. But before that, one study was published in European Stroke Journal from the SITS International Stroke Register. They found that a proximal occlusion may predict an early neurological deterioration. And in the study published in Stroke in 2020, the patients with early neurological deterioration underwent a rescue EVT. And this resulted in a good functional outcome in 73% of patients who underwent that procedure, compared to a 31% of patients who did not undergo rescue EVT. The next important concern of EVT in this subset is the safety outcomes. How bad is the symptomatic ICH? And we know that that is the most important predictor of mortality in a large vessel occlusion after recanalization. So with this background knowledge, I will go to the data. What does the current evidence show? This is a meta-analysis published in JAMA Neurology in 2020. They compared EVT with the best medical management, which included IV thrombolysis in the window, and after that antiplatelets. So what here we can see that there was a comparable 3-month functional outcome, that is an MR score of 0 to 1. This was comparable between both groups, mechanical thrombectomy group and the best medical management group. Then they performed a meta-analysis of 4 studies comprising of 843 patients. Surprisingly, they found that symptomatic ICH risk was higher in the EVT group, and this was statistically significant also. After this study is a prospective observational study from 3 international cohorts. It was published in Neurology in 2020. And here also we can see the outcomes. Functional outcome at 3 months was comparable between both groups. But the secondary outcomes or the safety outcomes, that is the early neurological deterioration and a 3-month mortality, these were significantly higher in the EVT group, and this was statistically significant also. This recent findings are also going in tune with the previous observational single center studies. The Saraj et al. Study, this was published in Stroke in 2018. They found that EVT had a higher mortality, coming around 9%, and a high risk of symptomatic ICH around 5.8%. And another single center study by Astagi et al., again it was published in Stroke. They also found that there is a mortality of 5% and ICH risk of 4.5%. In a severe stroke, we know that ICH risk is there, and we are accepting that risk because of the severity of the stroke. But in a minor stroke, the thing is, how should we accept that risk of ICH, which may even improve otherwise without an EVT? So this is another observational study. Again, they compared EVT and AVT with comparable functional outcomes at 3 months. But they found that a mortality was higher in the EVT group, and symptomatic ICH was also higher in the EVT group. Also, they found a trend towards a higher 3-month MR score, but it was not significant. So this picture clearly shows the 3-month functional outcome is comparable between the 2 groups, both EVT and IVT groups. This another retrospective observational study. Again, they assessed the efficacy and the safety in mild strokes with a large vessel occlusion. In addition, they also assessed the importance of site of occlusion. So in this, they found that the risk of symptomatic ICH was again significantly higher in the EVT group. In addition to that, they compared the medical management and endovascular group. They compared 3-month functional outcome according to the site of occlusion. The image in the A palette actually shows proximal occlusion. That is an ICA, terminal ICA or M1 or a tandem occlusion. We can clearly see that there is a benefit of endovascular thrombectomy. I completely agree with my friend in this regard. MRS 0 to 1 at 3 months is significantly better with the endovascular thrombectomy in proximal occlusions. But in the B palette, we can see distal occlusion, either a distal M1 or an M2 occlusion. We can clearly see 3-month functional outcome MRS 0 to 1 is comparable, or in fact, it is slightly better with the medical management group. We can clearly see in this picture. Then came the recent study. This is a multicentric retrospective study which was published in Annals of Neurology. The uniqueness of the study is that the patients presented in the 4.5 hours window, and they compared IVT alone with the bridging. What they found was excellent outcome in both the groups, 74% in IVT group and 75% in the bridging group. It was comparable without any significant difference. But symptomatic ICH risk was significantly higher in the bridging group, in the tune of a 3% versus a 7%. In addition, they also assessed the occlusion site importance. What they found was that occlusion site was a strong predictor of the effect of bridging on outcome. This picture clearly shows that in a case of proximal occlusion, the odds is favoring towards a bridging therapy. But in cases of distal occlusions, IVT alone may be advocated. So bridging had a good outcome in proximal M1 and even maybe distal M1 occlusions. Bridging therapy was even associated with the higher rates of symptomatic ICH in an M2 occlusion only. Next, I will speak regarding the Indian scenario. In India, IV thrombolysis is widely available in the primary stroke care center, whereas endovascular thrombectomy is a procedure which requires expertise and there are only very few centers where it is performed. Also, the cost of endovascular thrombectomy is a concern in a resource poor setting. So, the widespread availability of this IV thrombolysis and excellent recanalization outcomes in a distal occlusion or even distal M1 or M2 occlusion has got 50% recanalization with IV thrombolysis. This should favor IV TPA in this subset of patients. Before concluding, I want to show the data regarding thrombolysis and non-thrombolysis. This is a study published in Journal of Cerebrovascular Disease. What they have done is they assessed the outcome of patients with occlusion in the ICA or MCA in this subset of patients with a stroke score less than 5. What they have found is there was a higher successful recanalization. This study, they followed up with a repeat angiogram, either an MR or a CT angiogram, and they found that significantly higher rate of recanalization in the thrombolytic group compared to non-thrombolytic group. And neurological deterioration, either at 24 hours or at 3 months, was significantly lower in the thrombolytic group. Also, in this image, we can clearly see the 3-month functional outcome was significantly better in the thrombolytic group. Before concluding, this is a systematic review published recently. They have compiled all the studies, all the evidence till now regarding this subset of stroke. And what they found is that 60% of the studies, they found that symptomatic ICH risk in EVT is significantly high. Whereas only 4 out of the 10 studies showed primary outcome benefit in EVT. So this is again favoring. With this available evidence, I am concluding. Currently, the data with regard to decision regarding endovascular technique in minor stroke with a large vessel occlusion is uncertain. And the decision has to be individualized. Definitely, there is a subgroup of patients who may benefit from an emergent EVT. And what are the factors which may help in this identification of this specific subgroup of patients? Those are an NIHSS, presentation NIHSS, time from onset to presentation, and eligibility for IV thrombolysis, which is widely available in our country. And the site of occlusion. More proximal occlusion means favoring an endovascular therapy, and a distal occlusion, we should proceed with an IV thrombolysis. The clot burden and the robustness of the collaterals, which predict the infarct growth. So these are the factors which may help to decide on the subgroups who may benefit from an emergent EVT. And conclusively, all the studies have shown that endovascular technique is associated with an increased risk of symptomatic ICH. So coming back to our case, from all the data which I have shown, in this patient with a stroke score of 2, with a distal M1 occlusion, this patient is an ideal candidate for IV thrombolysis, and I would defer EVT in this patient. Thank you.
Thank you, Harikrishna. It was an excellent enumeration of the various studies that compares EVT versus IVT, and clearly have enumerated that there is increased risk of symptomatic intracranial hemorrhage and probably more deaths in patients who have EVT. However, there can be a bias because all of these are retrospective studies, and I would like to call up to offer a rebuttal as to how he would see these the findings of these retrospective studies, which claim more, could sort of offer explanation for the same.
Thank you, sir. I also would like to thank Dr. Harikrishna for a wonderful debate. I would like to offer my rebuttal. First, the point was he mentioned that there are a lot of randomized trials like the Mr. Clean Escape and along in the Hermes data. But my point is that, as I've highlighted, most of these trials took up an NIHSS of more than 5, which I said the largest chunk beyond. But the most common strokes are the ones which have a low NIHSS of less than 5. Among these trials, only Mr. Clean was the one who took a much lower NIHSS patients. Now, Coming to the Hermes data, even among, I have particularly selected the number of, in the particular graph, I've particularly selected at NIHSS of 5. Even then, the red triangles are the ones who underwent intervention, whereas the blue dots are the ones who underwent conservative therapy. This is from the Hermes data. Even then, among these patients too, who had an NIHSS of less than 5, as we can see, those who have a red triangles are much more lower down in the graph along the y-axis, who had a better functional outcome around MRS of around 2 at the end of 3 months compared to those who had a much poorer outcome in the control group. This is like saying that we have a person, EVT, a very strong person, but who is not being allowed to take up patients with an NIHSS of less than 5. We know that he is strong, but we need to make sure that all possibilities are used. Hence, the most important thing is that we need to go by evidence. What is the evidence? Definitely not clinical case reports or case studies. We need randomized control trials. We have 3 in the pipeline, the in extremis that is going on in France, we have the trimis in Florida, and we have the endolo in North America. Now, we've spoken enough of the problems. Now, very quickly, I'll talk about 2 slides on solutions. First, we need to rapid. We need to immediately make sure that we have the mismatch volume or the mismatch ratio that comes to the clinician on the phone when he's in the hospital cafeteria, so that he's immediately able to decide and take the patient up for EVT. So that the numbers that we are seeing on the right hand side of this graph for NIHSS who are less than 5, the results of the RCTs, which will be probably come next very soon, will be my best rebuttal. Thank you.
So, Dr. Vikram, do you want to add something?
I think we need to call Harikrishna for the rebuttal, and afterwards we can.
Thank you, sir. Sir, my friend has already shown that the Mr. Clean and all those data, the Hermes data, but clearly only in Mr. Clean they have enrolled patients with a stroke score of till 2. All the other studies, the significant proportion of the patients were NIHSS more than 10. So we cannot extrapolate that data to the in this specific subgroup of patients with an NIHSS less than 5. Second thing, I completely agree to my friend. There is good outcome with endovascular therapy in minor strokes and major strokes. But what we need to understand is EVT is not a simple procedure. It has got its own complications, especially in patients with the distal occlusion. There is a high rates of symptomatic ICH. And from all the data which I have shown, there is definitely increased risk of mortality. And the comparable outcomes are also not very different between these 2 groups. Second thing, the other point which I would like to tell is that many of the studies where I have shown were also prospective. Till we don't have any randomized control data are available at present, but some studies which I have shown are prospective studies. So without evidence, how can we do harm to a patient when already the existing modalities are showing benefit? So that is my point.
Hari, I'd like to stop you there. Suhas,
Yes.
Can you offer any 1 or 2 points to say why you think the symptomatic hemorrhage rates were higher? Were there any different cause for the mechanism of the stroke? Say, were there patients with intracranial atherosclerotic disease more common? Were there any studies that looked into those things? Or were there patients who had deeper infarcts and therefore more risk of symptomatic intracranial hemorrhage?
No, sir. And one possibility definitely the site of occlusions can matter. Proximal M1 is a long segment. It begins from it's a pretty long segment. But more importantly, it also depends on the type of clot, the characteristics of the clot, and thirdly, the time. We need to make sure that as the infarct settles down, as the clot settles down, the moment we are trying to remove the clot, there is a higher chance of thrombectomy. We are trying to save the brain tissue, but as a result, there is a chance of the patient can have symptomatic ICH. But
so thank you very much.
No, any questions or comments from other participants? Okay, if there are no questions, Raj, what do you do? in your center?
Yeah, it's a very challenging sort of decision-making process. Certainly, as Harikrishna has pointed out, all these trials have shown the higher ICH rates and mortality in that subset of patients. However, if you go and look at this data, what we see is that they have taken patients for thrombectomy who have IC occlusions and proximal M1 occlusions, and the distal ones they've left for medical management. So clearly there is a bias there when they have selected patients for treatment in terms of EVT or medical management. So therefore there is a clear variation in the baseline factors of these two set of patients. So what we have seen is if patient comes very early and they have a proximal M1 or IC occlusions, they are more likely to deteriorate. Say, for example, if the same patient comes 12 hours to 18 hours in a later window period, they generally don't deteriorate that much. So clearly, if they are coming very early in the window, then we discuss with the family as to there is a very high risk of deterioration. Nearly 40% is what I quote to them. And then it's really a combined decision, because if the family agrees, then we go ahead for thrombectomy. If not, then we keep a very close watch. What we have also seen is that if you go for thrombectomy at the time of deterioration, they don't do very well, because at that time, probably the core is much bigger and we have actually lost the window period to intervene. And they are probably not recognized early enough in the ICU. So that is one of the problems, that early deterioration may go unrecognized, and we have to have a very careful watch. And one more thing I would like to add upon is maybe we do a perfusion study in this subset of patients. And we have to understand the caveats of perfusion study, like the software has to be delay and dispersion corrected, and look for the penumbral volume. Second thing is you may want to take a DSA and see how the collateral flow is in that territory. Thirdly, you may want to think whether ICAD could be the cause, intracranial atherosclerotic disease, depending upon how the occlusion looks like on CT angio or DSA. And then take a conscious decision of whether you want to intervene or not. And maybe I'm looking forward to studies which look at low NIHSS, large vessel occlusion, and try to categorize that subset of patients based on DSA or perfusion imaging, looking for etiology in that particular patient to say this patient is suitable for thrombectomy. What are your thoughts?
Vikram, can I just
Yes, ma'am.
one point I would like to highlight is Rajas clearly. I think we should congratulate both the debaters. They have done a wonderful job, actually.
Yeah.
So what I would say is that 2 points I would like to say is with regard to the low NIHS, what we have found in our setup also, when they come with a low NIHS, look at the pattern of the infarct. That is one suggestion I would say. Most of the time from the pattern, these kind of patchy small infarcts you see and an M1 occlusion, many a time they turn out to be ICAD. So in those patients, those are the difficult patients, and that has been shown in the Journal of Neurology study, where they looked at the patterns and looked at decision of ICAD patients doing intervention. So in these patients, when the NIHS is very low, and these are probably an ICAD group, that is one group of patients I may be a bit selective about and a bit conservative. But otherwise, early when the patient presents, the decision is discussion with the family and they decide.
Vikram, can I come in?
Yeah.
So actually what we had few experience, initially we never used to intervene in such low NIHS occlusion, but then we had few catastrophic issues when during the middle of the night patient worsened, and then we had a catastrophic outcome. So then what we start to do is that we do perfusion imaging and see if there's a huge perfusion defect, then we discuss with the patient's relatives and go ahead. So essentially the thing is that we don't want an middle of night an issue. So especially when the monitoring and all is not very rigorous, I do prefer to do a perfusion imaging. And if it's not an ICAD, as Madam said, ICAD is a difficult scenario. But if it is there's no ICAD and there's a large perfusion defect, double the perfusion defect, we'll go ahead and do intervention. And then after discussing with the patient.
But Srinivas, that is, I think that's what RCT is important for decision making.
Yeah, that's true.
The issue is the perfusion penumbra. If penumbra is big, usually the deficit will be more. We rarely see a patient where NIHS is low and penumbra is big. It is very rare.
That is rare, but we see. we see patients we had experience with, we didn't do anything, and in the middle of night, 2-3 patients worsened, complete cutoff. Yeah.
Correct.
I think we don't know who are the rapid progressors and slow progressors, how they progress and why they progress. These are the things, I think, unanswered questions. And if we're able to answer them, then maybe we will be able to tell who to go ahead with.
There was a question. Is there any role of doing an MRI and looking at a diffusion flare mismatch? And if the mismatch is more than a point of taking these patients for a thrombectomy, like they did for diffuse 3, like if the diffusion shows a 70 mm core and a flare shows maybe a 25 mm, something like that. So should we then take these patients up for thrombectomy, considering that they'll eventually make an infarct that big?
I think the aspect, the NIHSS and the collaterals, they all go together. If collaterals are poor, the aspect will be big and the NIHSS will be more. So even if you know that if aspect is good, means it indicates that the collaterals are good. And in those patients, the NIHSS will be less. So again, this mismatch and all, wake up and all, I think those patients, whether we should take up early, it is a difficult decision.
It's okay.
Raj, what?
Suhas, DWA flare mismatch doesn't mean anything really other than just identifying the time, potentially identify the time of onset. Because DWI, whatever you get, the core is the core. Yes, DWI reversal is a phenomenon that has been described, but whatever reversals we have seen so far is maybe in the extent of 2-3 ml. And large DWA reversals are very uncommon, although we have had some patients with large DWA reversal. And that may be because of the DWI technique. Okay, this is not corrected for, it is not statistically corrected for. There is some DWI kurtosis imaging, which really looks at DWI in greater detail. And we may be able to establish what the true core is. Currently, the DWI, that takes longer time for imaging and so on and so forth. In general, DWI reversal is extremely uncommon. And if it reverses, it's for small volume reversal. Large volume reversals are uncommon. So you have to go by the DWI volume. DWI flare mismatch is not penumbra core mismatch. It doesn't go for that. Okay, it can potentially give you there was a plea-flare study where there is a DWA positive lesion, but flare is negative. Then you can potentially say it is less than 4.5 hours onset.
So Raj and Gigi, and we have Vikram there. So, I had this opportunity of presenting the same debate in this International Stroke Conference 2 years ago, and the same problem. And I was faced with the PI of the In Extremis trial, who's actually doing this trial, which is a low NIHSS on both ways. So the biggest question which came to my mind when I was reviewing this, and of course in day-to-day practice, is, as an interventionist, you people can answer it better, is that you're going to make it worse by occluding the vessels sometimes and depleting the collaterals further, or actually distal embolization into the vessels, which will be perfusing the collaterals as well. So what's your take on a practical perspective when you actually deal with these patients would be a key, because there are lots of students who in the night will have this call, and the interventionist student as well. And then it falls back on making this back and forth decision, and the patients are not, it's difficult for the patients in the night or an early morning to make such a decision because they want that the patient should stabilize or get better. So from a practical standpoint, what is your take on this as an interventionist?
As an interventionist, we also worry about the distal embolism, making the patient worse. Having said that, the instrumentation has improved significantly over the last few years. So we have large bore catheters, we have the stent retrievers, we have balloon guide catheters. So therefore, the risk of distal embolism is significantly, I would say, has gone down. Although having said that, I think if patient comes early in the window, say for example, less than 6 hours, an IC occlusion, proximal M1 occlusion, I would potentially consider going ahead with intervention, provided the family agrees there is a small chance, I would say a 3 to 5% chance of something going wrong, although the patient doesn't have a deficit at that point in time. So if they agree, then I would go for intervention. Otherwise, a very careful watch. Clearly, they are at much higher risk of deterioration when they come in less than 6 hours. So then ICU has to be fully alert to it, and then keep the pressures up. And if there's any worsening, then just go for intervention.
Same thing, sir. I see occlusion, whether it is a proximal or distal, that is important. If it is a proximal occlusion and cross flow is good and NIHSS is less than 5 because of the small emboli, I think in those patients, usually we don't touch it because the thrombus load is very huge. So except carotid T occlusion and proximal M1 occlusion, whether we should touch it or not, that we need to decide depending on the patient profile and the family, whether they're ready to take the risk.
Vikram, can you hear me?
Yes, yes.
Yeah. Thank you. I think a very great discussion. Just see, one of my experience has been this window period is very important, even in the intervention. Even though we talk of dawn and diffuse, we forget the core issue sometimes. So even when they are little big, we go ahead at 16 hours, 18 hours, and many times they have complications or bleed. So I think this window is extremely important. We should not lose sight of it. So in that context, I would like to ask you, from your experience, how common you get bleeds following intervention? We have been getting bleeds. I once called Vikram also about it. Does it have to do anything with the heparin which we are using, or do you think it's because of the time duration that we do it after, let us say, 12 hours, 13 hours? So I'm asking post thrombectomy bleeds. Can you tell us something about your experience and how to minimize it?
So post thrombectomy, it all depends on the core. If core is big, that is one. The chances of reperfusion is more. Second issue is the blood pressure. So blood pressure should be brought down immediately when there is a reperfusion, even if it is ICAD or it is an embolic stroke. Keeping the BP high is one of the risk factors, and remaining other risk factors, hyperglycemia, all those things we need to.
I'd like to add one point to that. So among the core, the deep infarcts are the one which will bleed. So the massive bleeds, major bleeds, if they have a big deep infarct, and all the cortex may be preserved, and once you reopen, reperfusion of the deep core is going to bleed, and if it bleeds, it predicts outcome. If you have a cortical bleed, it is not that bad. You can even decompress, they're okay, and they do well. But if they have a major deep bleed, then they don't do well. So deep infarcts, large deep infarcts, more than 6 hours, 12 hours, then you have to be cautious about large deep infarcts.
So you have to give some heparin, little bit of heparin you have to give during this thing.
Sir, if they have not been, sir, I think the bleeds are mostly related to reperfusion, not the heparin, because the heparin stays for few hours. I mean, maybe we give 5,000 heparin also, it will stay for 2 hours. So
And
the
this,
bleeds
and in some situations we give that heparin after having given IVTPA. It doesn't matter, you think?
That will be determined by the core. If there is a large infarct and you want to give heparin, then it will add to it. But most of the bleeds are reperfusion related. Of course, the drugs will contribute to it, sir. But deep infarct, large core, you have reperfused, then they are likely to bleed.
Yeah. But we can't avoid heparin. That has to be given, that 5,000.
Initial during the
even TPA, I think you can reduce the dose or you can avoid.
Yes, okay. TPA we do avoid.
Okay. Thank you, sir.
May I intervene here? Thank you very much, Raj, Vikram, Dr. Kaul, and both the presenters. I think it was a great session. Thank you for being there.